surgeons in a structured report of a fracture. Dr. Sahu is a consultant radiologist with musculoskeletal interest at London. He is a senior lecturer at University of Buckinghamshire in the NHS and has an experience of more than 20 years with close to 10 years as consultant radiologist at London Northwest Healthcare University. He currently works with HCA and Circle Health Groups in London. He is a reviewer of several referred scientific journals, including the British Medical Journal and Journal of Hand Surgery. Sir is an expert in musculoskeletal and sports imaging, both diagnostic and intervention. It's my pleasure to invite Sir and a speaker who was earlier an orthopedic surgeon and then migrated to radiology. We can also ask him which is greener in the QA section at the end of the talk. I It's a warm welcome, and I'm sure the audience is going to get the best of both fields and an input from an orthopedic surgeon and a radiologist. All over to you, sir.
Thank you so much, Dr. Chinmay. Very kind of you for a very good introduction and giving me the opportunity to present this webinar. Um, so you have given me my introduction. Briefly, I would like to just tell a little bit more about myself. That I did MS Orthopedics from Bhopal in 2003 and then did senior residency from Delhi. And uh, then I decided to come to UK in 2004 and took the PLAB exam, came to UK and worked in UK in orthopedics for another 5 years. So that was really good because I have seen orthopedics in both the countries, and I worked as research fellow and registrar in orthopedics, did foot and ankle fellowship as well as shoulder fellowship. And as I was very intrigued to see the orthopedics, the way it worked here. It was very fascinating, and it was interested. I was very interested, and then something happened, and my mind changed in 2009, and I decided that probably orthopedics is, or rather than orthopedics, I would like to continue and do radiology. So I decided to change career path in 2009 and took the training scheme in Southwest Peninsula, which is a very beautiful part of the southern coast of England. And I trained myself there for 5 years and became a consultant MSK radiologist. And since 2014, I've been working in NHS as well as in private sector. So I do work with a very big team of orthopedic surgeons and rheumatologists as well as sports physicians in both areas in NHS as well as in private sector. I do lead few MDTs, including the sport MDT, which is quite beneficial. And I myself would say that I have learned a lot from rheumatology MDT as well. So that is very interesting over the years, that how it changed your perception when you mutually talk to your clinicians. What are they looking for from your report? And that is why I decided to keep this very simple topic. But I find it very interesting because I end up going to my colleagues and we discuss about the reports, what somebody else have written, and why they have just left it very short and not mentioned about the information which was already there. So that is where I thought that I will just convey this message to the broader audience, and it might be useful to all the other radiologists. So we all know that orthopedic surgeons, and when I was there, they are very good in looking at fractures themselves. So they can look at their own plain films. They're very good in that, and they are very good in looking at CT scans as well. The subspecialty consultant, especially if it is a consultant knee surgeon, consultant hip surgeon, they can read their MRI scan as well. But there is added value which we can add to them, and that is where I think my message I'm going to convey about in today's talk, that we need to look for our added value, what else we can add, because we all are working for the best interest of the patient, and that is where we need to make sure that we are doing the mutual goal of getting the patient better. So if there is a plain radiograph, I would emphasize, I usually would say that please just don't say no bony injury when there is a whole lot of information there in that particular imaging. So this happens very often because a lot of us come to the hospital in the morning and there's a plenty of emergency department plain films or the inpatient plain films we have to do along with our dedicated work, and we all like to warm up by doing those plain films, and we go very fast, and sometimes I end up seeing a lot of issues which could have been answered just by the plain film, and they wouldn't have needed any cross-sectional imaging in form of MRI or CT or anything else, and the answer was there. But because somebody didn't take the effort to write any few extra line, or probably they themselves didn't know the importance of that. So that's why I would say that if an information is there on, say, for example, plain film, please do mention it. It can be very, very helpful, especially osteoarthritis in on all the plain films, calcific tendinitis in the shoulder, enthesitis in the ankle view on the lateral film, loose bodies in the knee, causes of any causes of locked knee or avian of the hip, which can be missed if we are not looking for it, and if we are only looking for the fracture. Then our role is very important in mentioning about any incidental finding which we can will see, or any normal variant, because sometimes the clinicians may not understand about those incidental findings and the normal variants, and the fracture clinics which are run along with junior doctors. I have attended the fracture clinics in Bhopal where we used to see 100 patients in like 2-3 hours time, when consultants will be there, but resident will see most of the patient. And I would say that it's very useful for them to have more information rather than thinking that this could be something which could be fracture, or they could be worried about that. So we can tell that this is normal variant and they can just not be worried about that particular finding. And that can be useful to a lot of people, I would say. Comparison with previous is one thing which we have privilege, we have the infrastructure to do that, because we have our workstations while we are reporting in proper ambience and in the proper reporting technique. Then obviously, with according to our DDP, the previous films will load up, or we can look for them, and that is very, very important, because sometimes you would be wondering whether this is a new finding, whether it's not a new finding, and you're umming and ahhing, and that's really good for the patient if you can compare and mention that no interval change. And I usually tell my other colleagues, other general radiologists, because everybody reports plain films. Some of these consultant on call, they will report fractures as well on the cross sectional imaging, and that's really, I would say, the comparison with previous adds significant value to any fracture management. We While doing the reporting, we can always mention about any interventional radiology management options, and we can be proactive. So I usually take this proactive, that is my approach both in NHS as well as in private, that I do tell them the next line of option. What do I think will be the right thing for the patient? For example, if I'm suspecting a calcific tendinitis on a plain film, which is very faint, and I'm not clear, I usually, if I've seen that film, say 8:20 in the morning, I would tell them, please get the patient in my ultrasound list at 9 o'clock in the morning. So that is something which I can obviously help, and that's where a lot of value we all can add. Virtual fracture clinics are getting more and more common, and when I was an orthopedic surgeon, it was not in trend, so we didn't never did virtual fracture clinics. But since 2015, 2016, the virtual fracture clinics started, where the patients are either seen on video consultation or they are seen through telephonic way only. And based on the plain films or based on the imaging, what has been done just to reduce the load in the hospital, and this became more in trend since COVID, and now this is the way to take it forward. But I would say there's one disadvantage of virtual fracture clinic, because even nowadays, if a radiographers come to me and they tell me, Dr. Sahu, what do you think? Is there a fracture or something? And if I'm not convinced myself, I usually stand up from my desk, I go to the patient, I practically palpate that particular area and elicit the tenderness, even now as a radiologist, and I enjoy that. That was the advantage of when they were seeing the patients in person. So I would say that in virtual fracture clinics, our role has become more important, because we have to be careful and giving them more and more information. One thing which always comes to my mind, and which is a comparison between general radiologist and MSK radiologist, that our specialty is something which we do not get many discrepancies. We do not put many discrepancies for other colleagues. But I would, because for example, if there is a general radiology case and something is missed on a chest, abdomen, pelvis, a big lymph node, somebody will put a discrepancy, yeah, and there will be discussed in the learning meeting and realm and real meetings. But at the same time, if something has been missed in MSK, it is actually not usually given that much priority. But I would say I'm not talking about missing fractures, I'm not talking about missing big thing, but I'm talking about something why which the patient will keep suffering. So those are the things. Patient goes through a lot of morbidity and suffering, and that's where we can reduce the suffering. And that's why I'm saying that not only the fracture, we have to mention about all the other things which are there on visible on the imaging. So what does this actually matters to the orthopedic surgeon? So I would say the most important thing for them is whether it's going to be surgical management or conservative management. And that's where when a surgeon gets an email report, he should know just by looking at the report whether it's going to be surgical or conservative, because these reports are sent to them by automated system and they are not aware at that time, they have not seen, they are not on PACS. So that's where if your report suggests them that they need to have this patient managed operatively, it helps in triaging them. And second thing is the degree of urgency, because obviously we would write degree of urgency, but I give a special importance to the cases where the patient might need urgent surgical intervention, and that's really important. From that should just immediately come from our text report. Whether the patient will need any further modalities for further assessment of that fracture, whether MRI is a better option or CT is a better option, I would say that this should also be clear, and that is where we can add automatically rather than waiting for them to call us or discuss with us. And I think we can tell them better from our experience that which will be the better modality. Something which is again comes about often is the age of the fracture, because I try not to write in my report without giving effort saying age indeterminate fracture. I try to look for all the other ways of resolving that, and we will come back to it when we will talking about this in more detail. And then whether the patient needs to be discussed in the multidisciplinary team meeting. So that's another thing, because we can add during doing the report, our software allows us to add the patient to MDTs and or teaching files, and all of those can be done at the same time. So while we are doing the structure reporting, obviously we have to tell whether what exam we are reporting, what views have been taken, what sequences have been performed in MRI scan. We have to mention about the exact location of the fracture, what are the orientation of the fracture fragments, how much is the displacement, how much is the soft tissue involvement, if we are able to tell that, or whether there is any joint involvement, and if there is joint involvement, whether there is a step, because that's where it's very important from orthopedic point of view, where they do not want to leave that because that can develop secondary osteoarthritis, and that is a very important discriminator, and we have to mention that categorically whether there is intra-articular involvement or whether it's a extra-articular fracture. So those things are really crucial in our report, and I would say that we can easily say that it's just a proximal tibial plateau fracture and say urgent tag and get out of that film. But I would say putting all these films together or points together, it can make your report which the orthopedic surgeons are going to like you. They will come to you and they will discuss with you. So that how you make your reputation as a radiologist, where they will be looking for you and they will be looking and wanting your advice, and that is really important. Although we think a lot of time it's simple, but I think it's just as I mentioned earlier, it would help in patients management. Measurements are also important, like how much is the angulation in the fracture, how much is the displacement, and what is the degree of comminution. I'm not an advocate of using too many classifications, although when I was doing orthopedics, we were taught a lot of classifications, we were quizzed on classification during our board round, but I would say that only try to use very commonly used classifications these days, because some people may get confused and actually describe the fracture more. Another thing is, in cases of sometime healing fracture or subacute fractures, it is very important to mention about whether there is any degree of malalignment, whether there is any callus formation, whether there is any evidence of early AVN, if you are able to see that, or whether there is any joint incongruity, which I have already mentioned. So that these are the important things which we need to take into consideration about writing the structure report. As I mentioned, grading is important, whether it's just mild comminution, severe comminution, or just or moderate comminution. There could be some differential diagnosis, and I will discuss this in my further presentation, where it could be some mimics of the fracture, and that could be considered while giving the differential diagnosis. I have already mentioned that we should take the lead in recommending for further imaging management options. There are a lot of my referrers who have complete faith in me, and for them, I usually tend to arrange the next investigation myself rather than waiting for them to request the investigation, and then that things can get further delayed, because time is also important in the fractures, because we do not want to have malunion or delayed union. So clinical significance, whether it's acutely urgent or whether it's relatively okay to treat, that is again we have to convey in our report. Interdisciplinary communication, for example, there is a patient who has have injury to their hand, or they might need hand therapist involvement to begin with early. For example, there's a volar plate fracture. So I will put a mark to attention of this interdisciplinary communication. That's also crucial, because obviously these fractures, till they wait for the fracture clinic appointment and they are referred to them, can delay because they need early mobilization rather than immobilization. So this is really good example of interdisciplinary communication, which can result into very good outcome. Otherwise, patient can end up in having stiffness. Conservative treatments, like some cases can be deemed for conservative option, and being doctors, all of us who are attending this webinar, I would say that conservative option to begin with is the best option, and if we are ourselves suffering from some problem, we would prefer conservative management if we do not have to go through the knife. But conservative treatment sometimes might need very close follow-up, and that's where we have again crucial role to look for whether there is any further displacement in the fracture, whether there is anything which is untoward or any adverse thing is happening. So all these things we should be discussing with our orthopedic surgeons colleague, and looking for the best management outcome. If the investigation has come from some other team, such as medical team, emergency department, or physiotherapist, then obviously if we think that it's this fracture need orthopedic attention, they should all be reviewed by orthopedic surgeons, and then they decide whether this patient will be conservative management or operative management, and that's how the patient should be managed. Some are the issues which I usually come across, and we had a massive team of radiologists in our trust. We have 3-4 sites of in NHS trust, and we have 56 radiology consultants and around 30 to 40 registrars, and we have 20 reporting radiographers. So we have a really big team, and all of us, we end up reporting these plain films, but there is a huge variation among the report quality. And I sometimes take lead, and if I think something has been not mentioned on the report, I do send email to everybody, and which is usually taken very positively rather than criticism, because most of my colleagues know me that I would not unnecessarily write an email, and I do not point out for a particular person or do not give an example, but I tend to mention generic things. And there is a lot of scope for enhancing our reporting skills in plain fracture reporting along with fracture reporting. So I would say that the information about patellofemoral osteoarthritis is often missed when you have found a fracture and you just mention the fracture. Similarly happens with foot injuries, like midfoot arthritis is something which can be quite debilitating, whether the patient has got hindfoot valgus deformity or they have got vasculitis. This has to be mentioned in the report. That is along with fracture, not only that the fracture has to be mentioned. Then a lot of time I find first carpal metacarpal joint osteoarthritis, which can be a cause of significant problem. Osteochondral defects, most importantly, I would say in the ankle and the knee. And I do mention in my report when I'm saying no money injury, I would say no osteochondral defect or loose bodies. So that is why where I am looking actively for osteochondral defect, and that I make sure that I do mention it. And I feel really bad when it was there and subsequently an MRI scan was performed, but the plain film done previously was not mentioning about it. So periarticular osteopenia can be a sign of inflammatory arthropathy, which should be mentioned if it is seen on hand radiographs. Then in the shoulder radiograph, I'm particularly looking for subacromial sclerosis, Sorsal sign, glenohumeral osteoarthritis, or acromioclavicular osteoarthritis. These are the things which can explain a lot of shoulder pathology. I would agree that whoever MSK radiologists are attending this webinar, that a lot of issues about shoulder, we can tell the prognosis just by the plain film, that what are we going to find on the ultrasound scan or what are we going to find on the MRI scan. There's a lot of information there. If there is reduction of subacromial space, you can potentially worry about that there could be rotator cuff involvement. And these are the things, if not mentioned, can be missed and the patient can keep suffering. If you just say normal radiograph, then it's not going to be picked up early. And chondrocalcinosis in the knee is another thing which I emphasize, similarly in the wrist. Some occult fracture, there are some signs on the plain films which could be there, and we have to look for these signs rather than just directly organizing for a CT or MRI scan. And if we miss these signs, probably the diagnosis can be missed. For example, in the distal radial fracture, there could be elevation of the pronator quadratus fat pad, and that can give you a very important clue that probably you should organize and CT scan or MRI scan to confirm that fracture. And that can be very important if this is patient's dominant hand. And neck of femur fractures, there's a lot of discussions, a lot of guidance of neck of femur fracture, but usually still we miss them, around 2 to 11% of these neck of femur fracture on the plain film. Radial head fractures, we all know from our standard radiology teaching that Sale sign, anterior and posterior elbow effusions have to be mentioned, but still we do sometimes miss these occult fractures. Scaphoid fracture, again, standard teaching about getting the 2-week follow-up radiograph if all the 4 views look normal. But we should be looking for other carpal bones as well. And if there is any suspicion, I would say do not wait for 2 weeks, rather than arrange a CT scan or an MRI scan, whichever is available in your hospital immediately. Supracondylar fracture in the children, again, loss of alignment can be very important to look for, and we will discuss about this. So just looking at this plain radiograph, we can see there is a comminuted fracture of the clavicle, which is the lateral 1/3 of the clavicle. Then as well as there is a fracture of the lateral border of the scapula. So this is practically a floating shoulder injury. And this is a very serious injury. This does not happen by simple fall. This has to have significant trauma. So if the patient has got this type of injury, I would say, and the patient has not come through big rotatraffic accident mechanism and there is only plain film performed in the emergency department, I would rather like this patient to have a CT scan of the chest to find out any other injuries such as fractures of the rib or pneumothorax, which are often seen with these type of injuries. And this is really important because if we do not pick these up, the patient can keep suffering, and sometimes it may not come to the clinician's mind who are looking after these patients that there could be something much more sinister, much more serious, which could be lying along with these injuries. So I usually suggest we are often sometimes mentioned that we are a culprit of increasing our own workload, but at the same time, I would say that these injuries are serious and we have to make sure that the patient is safe and there is no life-threatening emergency which could be brewing there and could be sitting just by reporting of these fractures. And if the patient has got something more sinister, I think they should be in the medical ward rather than in the orthopedic ward. So we should always be mentioning about subacromial space, some calcification, looking for fracture of the scapula. These are the other things which we should always be reporting in our plain radiograph of the shoulder. So coming to elbow, we all are aware of the fat pad sign, and the SAIL sign we have discussed. Similarly, we should be looking for all the fractures which are around there. So try to do the magnification, try to zoom on the film, try to look for the continuity of the cortices. And if it is a pediatric age group, obviously these are the things which can sometimes missed. And unfortunately, I have seen in my 20 years of experience that some of these are often missed initially, especially the fracture of the internal epicondyle. This is the common fracture which usually get missed. And we have to make sure by our mnemonic, which we learned during our radiology training, to look for all the ossification centers because they emerge as the age of the patient grows. So by the age of 11, we should be seeing all the ossification center and none of them should be missing, including the lateral epicondyle. So if a child is more than 11 years old, then we should be looking for it actively, and we should be asking ourselves and challenging ourselves, have we seen all the ossification center? None of them are missing and none of them look rotated. So this is again textbook reading from radiology, but it's good to emphasize and revise this knowledge that looking at the elbow radiographs on the lateral view, we should be looking for the anterior humeral line, which goes from along the anterior cortex of the humerus. It should traverse at least 1/3 of the humerus on the lateral view, and it should pass through the middle 1/3 of the capitulum. So that is where, if this goes backwards, then there is an hyperextension type of injury, which is the commonest pattern of supracondylar fracture in children. And now talking about the second line, which is radiocapitular line. If we look at the lateral view and draw a line along the middle center axis of the radius, then looking at both the lateral view as well as the AP view, it should transect the capitulum. And that's where we can look for whether there is any subtle dislocation. And these are the things which we should be actively having in our mind, although we are not drawing the line all the time in elbow radiographs, but this should always be in our mind to challenge ourselves if there is any doubt, especially in the pediatric age group. That's where the injuries can get missed. This is the concept I learned first time in orthopedics. We had a big book called, which we used to use, called Campbell Orthopedics Surgery book. It has 4 editions. And this concept was quite elaborated in that book. And I remember doing my MS examination, and this concept was always mentioned about that the whole forearm is just one joint. And so we look at proximal radioulnar joint and distal radioulnar joint. We all are aware about that these joints should be congruent, especially distal radioulnar joint, which we call as drudge. But actually, if we look at supination and pronation, it happens throughout. So there is interosseous membrane in between, and this supination and pronation. This is actually just one joint if you look at practically. So the fractures which can happen at this joint could be Monteggia fracture, which is associated with usually the dislocation of the radial head, which can go in any direction. It usually can go anterior or lateral, and then the fracture of the proximal ulna. Similarly, the Galeazzi fracture is usually associated with disruption of the distal radioulnar joint, and that's both these fractures do need surgical management, and that's where they are very important to be described accurately. And I would say that this is crucial for us to mention it correctly in our reports, and then we have to put the urgent tags so that the orthopedic surgeons can pick them as soon as possible. Chinmay gave a very nice talk in IRIA where I was present, and I was giving the same talk with the shorter version about the eponymous name of wrist fractures. So I just thought I will just include this in my talk as well. So this is the die punch fracture, which is I have shown here, which includes a depressed fracture of the lunate fossa of the articular surface of the distal radius, and that is usually as a result of punching type injuries, which is usually very common in England following the football games. and that's where we see them more often. Then volar and dorsal water injuries, these are the fracture dislocation type injuries involving the intra-articular fracture rim of the distal radius, either on the dorsal or volar lips. And these most of these, if they are young patient, might need surgical management. Schoffer's fracture is the radial styloid fracture, which is also an intra-articular fracture, and it depends on whether how much it is displaced. Colles fracture is the commonest variant, which is usually the extra-articular fracture, and they are usually treated in the vascular after closed reduction if it is a displaced fracture. Smith's is the reverse of Colles, where they are low energy and volar displaced fracture, but these are the fracture. If they are to be treated conservatively, then they will need very close monitoring and to make sure that they do not get displaced in due course. So that means they will need weekly follow-up in the fracture clinics. So carpometacarpal joint fracture dislocation, this is something I like to emphasize a lot. And while teaching the registrars and my other colleagues, I always say that this is one injury you have to be very careful while reporting. This is something which I call as Lisfranc equivalent of the fracture dislocation, which can happen in the wrist instead of the foot. So we all pay a lot of emphasis for the Lisfranc fracture dislocation, but these are the injuries which are taken slightly less seriously. And I get quite worried about this because if there's a manual worker and if you miss this injury, and if it is a dominant hand, then it can add to the significant lifelong morbidity, which is very sad. And that is something, these injuries happen in usually young males, and they are young adult male. And this can be very, very serious if you do not end up picking it up early. And it is our responsibility as radiologists, if we are suspicious of, like for example, this you can work out that there is shortening of the fifth ray. So there is something going on in this plane, in this area. And if you look at the oblique view, there is also an overlap which doesn't help us. But there is, if you keep yourself and look at thinking about it, there is some shortening of the fifth metacarpal head. Looking at the lateral view, there is not much subluxation or dislocation, which can actually sometime may not be present. It could be quite subtle and depends on the orientation, whether the hand has been correctly, true lateral view has been acquired or not. And I would say that please have very high index of suspicion if you are looking at these injuries, because this should not be missed, and this can add to significant morbidity to the patient. If I see something like this, if I am asking myself that this doesn't look right, then I immediately recommend a CT scan to look for further injuries. And that is very, very important from patient's overall outcome point of view. So this was one case which is from our discrepancy meeting. Unfortunately, this was missed in our department, and obviously everything is quite easy in radiology when you look at retrospectively. But this case was missed and no bony injury was the report. However, if you see here, there is some volar placement of the head here. And if you look at fourth and fifth metacarpopharyngeal joints, I'm not very happy with the overall length. So we only had two views because in our department, we didn't used to do lateral view for every wrist case. So this patient came to the clinic. It was probably Easter or Christmas time after 1 week. And then subsequently a CT was requested, and CT found out there was significant injury involving the fourth and fifth metacarpal base fractures, which were comminuted. There was fracture of the dorsal aspect of the hamate, and there were subluxations of the fourth and fifth metacarpopharyngeal joints. So this needed going to theater and fixing, and but I would say that this could have easily be picked up if we were more suspicious about it. Again, no criticism, it happens in radiology, but at the same time I'm saying that this is something which I take it as serious as if I'm suspecting about Lisfranc injury, and I always tell my colleagues to please consider this. uh, quite seriously, because this can be missed potentially if you are not thinking about this. And you can easily see, I could not get the chance to upload all the images, but from these you can get a feel that it's quite tricky. So just a simple example, it looks very long, but this is for my own review of whether what do I want to say, what is important in this. So this is just one example I'm giving in the whole presentation, that what do I look for in my wrist reporting. So obviously distal radius and scaphoid, I think, are the most important leading question if they have written me push, which is fall on outstretched hand, and that's the history given, push query fracture. Yeah. So this is a common mnemonic they use here. Distal radial, so distal ulna and ulnar styloid is important because that could be associated. So I have mentioned whether there is no acute bony injury, I'm convinced from my plain film report. But at the same time, because it's hand and wrist, I would like to mention a little bit about if there's any erosive arthropathy, inflammatory component, any periosteal reaction, and particularly our surgeons, our hand surgeons, they do like us to mention about distal radial ulnar joint, because as I said, it could be associated with some proximal injuries, and then the patient might need imaging of the elbow as well as the forearm. Perineal fracture or dislocation, in all department you must be seeing this, that this is something which sometime you come across a case and you will think, oh, how on earth I missed this, but this does happen if you're not thinking about it. Similarly, intercalated segmental instability, whether it's dorsal or volar, so all this information could be there on the initial film. And you can also comment about TFCC region chondrocalcinosis. Just mentioning about some more configuration about the Bannett's fracture, Rolando fracture. It's good to use the term sometimes, but I would say that at least we should mention that it is intra-articular, and hand surgeon will end up fixing these fractures because Rolando fracture in particular is very, very unstable injury, and this needs immobilization, but at the same time will need internal fixation. So scaphoid fracture is something we all know, we all take very seriously, but it might happen that there might not be anything visible in the beginning. So we did a big study of prospective trial of 100 patients of scaphoid fracture, where we randomly allocated them to CT or MRI scan. This was all computerized randomization, and then we came up with that MRI scan is more sensitive, which if you think just logically, it is more sensitive, that makes sense. However, we could see that trabecular disruption was not picked up by CT as clearly as it was picked up by MRI scan. And although the patient may not, it will not change the treatment, because if it is not displaced, it will not end up having open reduction or internal fixation. However, it is very important from prognostic point of view, because here we see a lot of sports people, and for those sports people, when can they go back to their sporting activity? That's the important question. When can people with manual work can go back to the manual work? That's really important, and these are where our radiology prognostication comes very important and handy. So spine is something which again I would emphasize a lot, because there is a lot of value we can add by giving a proper report on the spine. We all, if we are reporting plain films, we can come across as a lot of spinal x-rays which might show some sort of collapse fracture. Sometimes the imaging can also be affected because of the penetration of the lateral view may not be very visible, but we are suspicious of a collapse fracture or a wedging or something. But what does it matter for the spinal management is how acute is that injury, because we do see it even with the patient might have had a fall, they are probably 60-70-year-old, and they come and we detect this spinal collapse. So how does it help the clinicians, because they are looking for whether is it the cause of the symptoms, or is it how old is this fracture. That's where we can add a lot of value, because if an orthopedic surgeon is looking at that, they may not be uh, fully confident whether this is the entire cause of the patient problem, because the patient might have associated fascial joint arthropathy, they might have associated disc disease, they might have associated spinal canal stenosis. So where can we add our value to this report? So I would say that if I see something like a thoracic or lumbar x-ray, I would look for all the imaging of the patient which they might have had. For example, a patient might have had 1 year ago, they might have had a CT virtual coronography. So that's my friend, because I can always do an sagittal reformat and look for whether there is any previous lumbar spine fracture. And that can immediately answer my question whether there is any interval change during the last 1 year or not. If the patient has a thoracic spine fracture and the patient has have had an HRCT, for example, during COVID times, and that will give me immediate answer whether there has been interval change, although it could be 3 to 4 years ago. But it's really important, because there is something is always better than nothing. And if you are lucky, you might find that there was already something there. And that is your immediate answer, because that will save you from arranging another investigation. Because it's very easy to say it's age indeterminate, but at the same time, I would say that if we want to add value and if you want your referrals to come back to you, it's better for you to give them the answer as close as possible. And that is again saves patient from unnecessary investigation. And in government sector, it can save you a lot of resources being used. I'm again saying government sector because that's where rationing comes in picture. But in private sector, really, for many people or many patients, it might not matter. However, I would say that it's our duty to report that whether it's an interval change or not change. I do tend to use Jenin classification if I'm seeing the osteoarticular fracture, because my rheumatologists are not interested in grade 1. They're only interested in grade 2 or 3 type fractures where there is collapse of between 25 to 40% or more than 40%. So in this STR sequence, we can see that there is an acute edema and there is a low signal serpiginous line. So that gives us immediate answer that this is an acute injury. However, you might not get that answer from CT or plain film that whether it's an acute injury or not. And if we are doing a report, we can always look for kyphoscoliosis, and we can mention about Cobb angle, we can mention about enthesitis on our MRI reports, because there is a possibility patient might have an underlying Engstrom or underlying rheumatoid arthritis which was never picked up before. Look, comment on the sacroiliac joint. I do see a lot of runners, a lot of marathon runners, ultra marathon runners in private sector, and sometimes the answer is there in the SIJ, because these people keep running and they end up having insufficiency fractures of the sacrum, which is not initially picked on the initial imaging. And even on the MRI scan of the pelvis, if you're not looking actively, sometime it is a possibility you can miss subtle sacroiliac joint fractures. So you have to actively look for it and mention about it. Spondylosis in young athletes is important, because you can see just the edema, but nothing else, and it could be unilateral, which can easily missed, because we do not do STR axials, we do mainly T2 and T1 axials on MRI of the lumbar spine. But I pay a lot of attention on the STR or sagittal STR sequence, and I go very slowly, especially looking at two lower lumbar levels. For stress fracture for adolescents, I do classify them as with Hollenberg classification, and that's where, because these are gymnasts or footballers, and it does matter to them that when can they go back to the sports, because if it is type 3 Hollenberg fracture, which is actually acute edema along the pars interarticularis along with cortical break, then they will need good 2 to 3 months of break from sports, especially football or gymnastics. So that is where we have to do a limited CT as well, because these are young patient, and mention about how much is the degree of bony bridging for them. So MRI has been proven, I'm not going to repeat again and again, is very useful for occult fractures, which can be missed on standard trauma scan. And occult injuries can be very useful, where MRI can pick this up. So an early diagnosis can have significant impact on the management, and it's proven to be cost effective. So these are the criteria which we use if it is persistent pain for arranging an MRI scan. and we do very limited sequences, but these are very useful in picking up the hip fractures. So looking at the hip fractures, as I mentioned, that 2 to 11% of the hip fractures can be missed on the plain film. And cost-effective wise, NICE guidelines in UK say that we should be arranging for MRI scan, but it is not always possible because of rationing. So CT scan is initially performed, and if CT shows the answer, then it's good. But otherwise, and if the patient is still symptomatic despite negative CT, then we end up having an MRI scan. We could have other injuries associated if there is no neck of femur fracture, that the patient might have pubic rami fracture or the sacral insufficiency fracture, and that should be picked up on these scans. So AVN is one thing which should not be missed by a radiologist, because it can add a lot of value to the patient and significant outcome if it is picked early. And I would emphasize that so many times when we are reporting MRI scan and retrospectively, if we go back to the plain films, we always say that there was a possibility. And a lot of times it happens to us, we feel really bad if it was missed, and it's a young patient who can have now lifelong implication for this, or they end up having a total hip replacement. So we should be looking for these AVN. This is something which we have to categorically differentiate between the AVN and transient osteoporosis of the hip, because this is an entity which will have edema in the hip, femoral head and neck. It can go up to the intertrochanteric region, might not have serpiginous low signal line as we saw in the AVN. It can have moderate hip effusion, and this is something which is self-limiting condition. So you have to categorically mention that this is transient osteoporosis of the hip, and this is mainly a stress response, very common in middle age or younger males. It can be common after the pregnancy. So this is something which is like a no-touch issue, where surgeons should not go back and do any intervention. The patient will only need a follow-up imaging. I would do at 6 to 8 weeks time, because it will usually completely resolve in 3 months time. Sacral fractures are also can be missed on plain films, and that's where I would say that we have to look for them, and cross-sectional imaging can be very useful. And this is where if the patient has persistent symptoms, that can be very useful. Stress fracture of the medial aspect of the neck is quite common in young athletes. Stress injury, who are ultra long distance runner, this is quite common, and this can give them prognosis that when can they go back to their sports. Usually I do see a lot of these referrals from sports physicians. Greater trochanteric fracture can also be sometime missed, but we have to be careful by zooming the film if it is just a plain radiograph, and not to miss the greater trochanteric avulsion fracture. MRI can give us the degree of injury, because there could be a lot of edema which could be traversing along the intertrochanteric line. Tibial plateau fracture, we might only come across lipohematrosis on the plain film, but we have to make sure that the referrer understand about the occult either proximal tibial or distal femoral fracture, and this needs to have an urgent CT scan. I'm going to skip this column concept for tibial plateau fracture, because we all predominantly look for these through CT scan, and a lot of people still follow Schatzker classification. This was a new concept introduced in 2021 and was published in Radiographics. But the bottom line was that if there is more comminution, the patient will need operative management rather than conservative management. So coming to ankle, this is a Masonova injury, which if you are looking at isolated medial side, significant soft tissue swelling, easy to say that there's just soft tissue swelling, but you have to worry about medial ankle ligament injury. And in that case, you have to always think about whether there is associated proximal fibular fracture, because that could be a part of Masonova fracture. So if it was not, orthopedic surgeons are again very good in picking these up, but I would say that if it is just by emergency department clinicians or from some like medical team, then I would suggest them that they should be arranging for a knee x-ray as well, including the proximal fibula. Chiao fracture is a Salter-Harris type 2 fracture of the distal tibia. anterolateral part where there is a displaced fragment commonly seen in adolescent, and we need to explain this in our report properly, so that the patient orthopedic surgeons, depending on the displacement and intra-articular involvement, how much is the displacement at the articular surface, they might do the operative management. Coming to pilon type fractures, again, combination matters a lot, because most of these are dealt with open reduction internal fixation, and we have to mention how much is the degree of displacement, how much is the is how many types of fracture, how many planes the fractures are going through. That is what we will mention. So I have already mentioned Lisfranc fracture dislocation multiple times in my talk, and we all take it very seriously. There is a very good awareness among the radiologists about the Lisfranc fracture dislocation, which is very good, and this prevents patient from having significant morbidity. But at the same time, I would say that still immediate CT on a small uh, index of suspicion is very, because we should have very high index of suspicion for these injuries, because they can have severe lifelong midfoot pain if these are missed in the initial phase. And there are two types of Lisfranc injuries. Either it is homolateral or divergent type. So homolateral, where all the rays have displaced to one side, usually lateral, and divergent type, when the first metatarsal base has displaced medially and the rest of the metatarsals have been displaced laterally. Thank you very much. So here I finish my talk. It is a broad topic. I wanted to keep it more generic for everybody's use, and to emphasize the salient feature which I thought were more important. Uh, but I'm very happy to take any questions whichever are present. So if anybody has any questions, thank you, Tanmay.
Yeah, thank you, sir, for that amazing session. And it was a need of the hour to hear from an orthopedic's mouth on how radiology reports sound or look like. So the first question is, after POP, after cast application, the fracture sometimes is not in anatomical orientation. So should we mention that in the report, or how do you word it?
So this is again, I can see where are you coming from, because you don't want to offend your clinicians, your especially your orthopedic surgeons, because they are your main referrers. And as a polite, being polite to the profession, and being the colleagues, they are extremely good in looking at their own follow-up X-rays. So I would be diplomatic in this question and will not mention until it's a significantly displaced fracture and you're worried about that the patient might not be seen or reviewed in the fracture clinic immediately. But I would say that they are very, very good in their follow-up. So I would say I would not mention until it's significantly displaced, because as I said, if it's not going to change the management immediately, they are, because these patients after having the check X-ray, they usually go back to the fracture clinic and they are picked up. But the other way of being polite and your referrers is you can call them rather than mentioning on the document, because patients do have right to see their reports as well, and in NHS app they can download the reports, so that can also become a bit of challenging issue later on to deal with. So it's better to just call the orthopedic surgeons or text them if you are worried about the patient sincerely. So that's how I will that's my answer to it. Thank you.
Oh yeah, thank you, sir. The next question is, after internal fixation, and if we still see maybe some displacement or any fragments that are often seen around the fracture site, but they're not part of, they have not included that in the fixation. So do we mention the sizes and orientation, or like how do you word them?
So once again, it does relate to the first question, because as I said, even for CT scan, the orthopedic surgeons are very, very good in looking at them, because in UK it's very subspecialized, like all shoulder, either shoulder surgeon or ankle surgeon or knee surgeon, hip surgeon. In India, when I was practicing, it was not like that. Most of the orthopedic surgeons were general orthopedic surgeons. I think it is getting more subspecialized now. Uh, our role in those CT, one thing which I forgot to mention during the talk was to tell about the additional findings, for example, a lung cancer in a shoulder CT. Yeah. But at the same time, regarding the fixation, because I've been on that side of orthopedics, uh, they know when they're fixing how many fragments they have to fix, and sometimes it is not actually very easy for us to sit in our office and to think adversely. Maybe easier that they have missed fixing this, or but I would say that they try their best to fix most of the fracture to the best possible outcome. Because one thing in orthopedics is also, which I think all of us need to understand, is that uh, this is very standard teaching of orthopedics, that do not cause disruption of the soft tissue to make the x-ray look better. And that's a very good phrase which I was taught in Bhopal on day one by my professor. Because you can look x-ray look excellent, but eventually, because you have ripped off all the vascularity, the fracture may not heal eventually. So they have to have a balance between those things. And as I said, you can say there's an extraarticular fragment, this and this noted, but don't give your judgment on that, and they can deal with this. Okay, thank you very much.
Yeah, thank you, sir. Um, how to grade aging of fracture? Uh, Oftentimes we don't have the history that when has trauma taken place. So how do you grade aging fractures, and especially in cases of spinal fractures also?
So that's why I was telling that we have to be as helpful as possible, and we have the weapon, we have the facility, we have the infrastructure to do that. So as I was giving you example, look for all your packs, because these patients, if they are old, they might have come with some other problem. Yeah, as I was giving example of CTVC or HRCT. So those are the spinal fractures. You can, if you can help with aging, like if there was anything before that, you can obviously know. But multiple times you do not have fractures, and I think your query is coming from there. You do not have any previous imaging, and in that case it's difficult. And so you have to advise either cross-sectional imaging in form of MRI, I would say better, because of the stir sequence. Because if there's no edema on stir, then clearly the mm, the fracture is definitely more than 6 months old or 9 months old, I would say. But if there is edema, you know that there is, and depending on the intensity of the edema, you will know how old is that fracture. So same can apply to multiple body part. I would say that if there is nothing previous available, then MRI is your friend. And if you're looking for callus, CT is your friend. So the definition of fracture healing is if it is more than 50% of the bony bridging, that's fracture healed clinically. So when I am writing a report for looking at the CT scan, for looking for fracture union, I mention about the cross-sectional area, how much is the bony bridging, and that term is very important for them. Because if we say bony bridging of 50%, then they take the immobilization out if they are happy for the patient to be gradually mobilizing. Because fractures, if over immobilized, as I was giving the example of volar plate fracture, that they can cause stiffness, and you don't want your patient to have a healed fracture but a stiff joint or useless joint. So that's very, very important. Thank you.
Okay, thank you, sir. On a similar line, there are a lot of questions asking about fracture healing, when to call non-union, and how to judge callus formation on X-ray as well as on CT, because that's
So
something that often, and when to call malunion. Sometimes it's just a bit of the healed part. So
yeah. So fracture healing, the definition, orthopedic definition of non-union is 9 months. So you cannot call something non-union before 9 months. Yeah. So that is very important. But on CT scan, clearly you are reporting a fracture when it is 6 months old. You can see sclerotic edges. You can see they are smoothened out. There is no bony bridging at all, and you can be tempted to say that it's non-union. However, as I said, that definition is 9 months. So between say 3 months to 9 months, that's the time when you can say it's a delayed union, because that's the correct medical terminology or orthopedic or radiology terminology. So I tend not to use the term non-union before 9 months. I describe all the findings, and the surgeon will immediately know that this is not going to heal. I might ask the history of diabetes or smoking, and the outcome, what is going to be. But as I say, if you want to be correct in your report, that is what you should do. And callus formation, as I covered already, like you have to determine on the CT according to the cross-sectional area. You have to look at all the three planes and then make your mind. On plain films, it may not be evident early on, but that's where the role of CT is crucial, because you can do a very limited CT to avoid exposure and too much radiation, and it can give you answer. So depending on, we are talking about when everything is available to you, and in an environment where you can request for the best interest of the patients. That's how I will proceed. Thank you.
Yeah, thank you, sir. That's all the questions, and thank you for patiently answering them and presenting a comprehensive review on fracture imaging. It was lovely to hear from you, and we hope to have you in future on this platform again. I'm also pleased to share that there were close to 300 attendees today from around 36 countries, and I'm sure they're going to love it. And people can access the recording on meditube.com if you agree to later.
Yes, I'm completely happy for it.
Thank you so much. Thank you.
Thank you.
So with your permission, I'll end the talk. I'll end the webinar here.
Thank you so much. Have a